Welcome to the CMEessentials podcast, covering current topics in clinical medicine. The show helps clinicians stay up to date on the current standards of care and catch up with the latest clinical developments and trends. Each episode features a lively discussion between the physician host and a noted clinical expert. They dig into the issues practitioners face every day and provide insight on improving patient care.
Hello and welcome to another installment of Oakstone's CME Essentials in Family Medicine. I'm your host, Dr. Brandon Fainstad. I'm an outpatient general internist at the VA in Denver and an associate professor of medicine at the University of Colorado. I'm thrilled to be teaming up with Oakstone to explore the evidence and best practices on topics most relevant to the care we provide. Today, I'm joined by Dr. Calvin Fu as we discuss the management of alcohol use disorder. Dr. Fu is the perfect guest for this session. He's an addiction psychiatrist and an associate clinic director for the Cooper Center for Healing in Camden, New Jersey. He has a wealth of knowledge and experience on the topic. Dr. Fu, welcome.
Thank you so much for having me today.
Our discussion is presented in two parts. In part one, we'll discuss disease burden and diagnosis, non-pharmacologic interventions, and ambulatory management of withdrawal. In part two, we'll focus on the pharmaceutical treatment and novel therapies that are receiving attention. We'll end each part with key take-home points. Before we dive in, Dr. Fu, can you tell us a bit about your background, including your path to addiction medicine, and what you and your colleagues are accomplishing at the Cooper Center for Healing?
Yeah, of course. So I grew up in Jersey, and I went to Cooper Medical School. I hadn't quite decided what I wanted to do in medicine when I got there, but one of the things that really drove me is that we had mandatory volunteering, which is always a little bit of a joke. But one of the experiences that we had was providing after-school help for kids in one of the local libraries in Camden. And one of the things that very much struck me was that some of the kids would get dropped off by their parents, and the parents would look intoxicated. But there was something about the dedication to taking care of their kids despite their active use disorder that struck something with me. Shortly after that, going on clinical rotations, it was a coincidence that one of those parents actually ended up admitted to the ICU. He turned out okay, but to see how difficult it is for people with active use disorders to navigate the healthcare system, that seemed to be something that would be really, really powerful for me to direct my career towards. Psychiatry seems like one of the best options for that, and I had a phenomenal time at my general psychiatry residency at Temple University Healthcare. And I finished with an addiction psychiatry fellowship over at University of Pennsylvania before joining Cooper. At Cooper, we're a multidisciplinary addiction medicine group. We have our foot in the outpatient, inpatient settings. We also have our own detox rehab that we have a partnership with in Cherry Hill. So we really do try to cover the full spectrum of addiction care. And there's something phenomenal about working with colleagues from across the medical spectrum. I have colleagues that are emergency medicine, family medicine, internal medicine. There's one person that's pain, palliative, and hemonc that we like to show off because we really try to make a point that addiction is a disease that touches so many different fields. And if we really focus on the individual, it's not like one person experiences addiction and is a cardiology case, right? There's always a little bit more. So we try our best to model our center in a way that really supports individuals in their recovery.
Yeah, what a rare setup you guys have. I can't imagine many centers like yours across the country. How rare is it?
You know what I'll say is, having gone through a few different places and seen how addiction is done, I do know that everybody means to really treat, but it's difficult when you have some places that have more historically what we say vertical integration. You have a department of psychiatry, department of family medicine, right? You bring everybody to the table. Everybody's well-intentioned, but has different philosophies about how things should be done. What I'll say is that the center at Cooper was horizontal. We are across departments, and it was built that way from the get-go to make sure that you don't have to bring people to the table. They're already there, and you don't have to disagree. You can have differing opinions, but ultimately, you know that the colleagues that you're sitting next to are the ones who have the same intentions to execute the mission. What I'll say is that I know that this model probably exists in a few different places, but locally, we're the ones that look like this right now.
Well, let's jump into it. Just as you described, alcohol use disorders a major challenge across the society and impacts patients in really all of our clinical practices. And just a few statistics to highlight the significance. In 2010, there was an estimated cost of $250 billion in the United States just to manage the complications of excessive alcohol consumption. And according to the CDC, 1 in 10 deaths in working age American adults is attributable to excessive drinking. And this trend has been increasing over recent years, particularly in women in their 4th to 6th decade, with a 30 to 50% increase in alcohol-related complications. What else can you tell us about the problems associated with excessive alcohol use?
What I'll say is that there's lots of statistics, and when you talk to people and you want to convince them, there's different ways to do so, right? If I talk to hospital administrators, I use dollar signs. If I want to talk to clinicians, I'll use statistics. And when I talk to patients and their families, a lot of it talks about the individual emotional impacts of how these things affect them. So you take your pick how you're going to take these. But I do like to lean on some of the wider accessible databases out there. So the NIAAA, or the National Institute for Alcohol Abuse and Alcoholism, that is one of the government agencies that records and reports on a lot of these things. A lot of the statistics are available there. So at any given time, about 10% of the United States population has alcohol use disorder, which if we look at our current population, is almost 30 million people, which is a lot of people. And it is one of the highest causes of death in the country. The number does creep up over time. I think the last time I checked, it was 140,000 a year. Alcohol, unfortunately, is also the second most common associated factor with suicide, and it's involved in maybe 1 in 4 situations where people complete a suicide. Not to say that's the worst thing that can happen, but if we think about other medical comorbidities as well, GI-related cancers, issues with diabetes, sleep, blood pressure management, complex pain considerations. These are alcohol use and alcohol use disorder and problematic alcohol use, which are all separate things. They are all independent factors in contributing to these issues as well. If we're looking at just livers, almost half of liver disease deaths involve alcohol use, which is, for something that's modifiable, it makes it very much a clear target for treatment. But like I said, if you're talking to different people about how to convey the weight of these issues, if we're looking at the amount of people that have a person with alcohol use disorder in their household, 10% of children have a family member that has an active alcohol use disorder. And not that we're going to go in today's recording, but if we think about ACEs, or the adverse childhood experiences, this is a measure that looks at the extent to which there is disruption and chaos in a child's life. And what we do know off of that is that people with higher ACE scores, more disruption and chaos in their life, are predisposed to not only more psychiatric and substance-related issues, but more medical issues, right? People with higher ACE scores have a higher predilection to develop diabetes and hypertension and things of that nature. And ACE scores, in a sense, beget more ACE scores. So this turns into generational issues. If you have somebody in a household that has an active alcohol use disorder and there's children involved, outside of mandatory reporting things of that nature, but you think about how this can cause downstream effects, even if they're slighter to their kids and their subsequent kids.
Yeah, that's such a good point of the butterfly effect and how important it is with each patient encounter to try to address not only their own life, but all the lives they associate with.
Yeah, I'm a psychiatrist. There's a lot of stigma around mental health as it is. And I do recognize that the people that I see are the people that are looking for treatment. Sometimes I'll throw in a little bit of a quip and I'll say, this is going to come off as emotionally manipulative. I'll be right out when I say that. But when it comes to their substance-related goals, not even related to alcohol specifically, but nicotine especially, I'll say, think about how this affects your kids and what you're modeling for your children, right?
Mm-hmm.
And I'm glad that you're here. It demonstrates that you're taking care of yourself, which is a really, really important for your kids. But at the same time, too, think about how continued use and not continuing to work on recovery is going to show how your kids should access these things in the future.
All right. Well, let's jump into a case. We'll hear from Dr. Lydia Calamari, an internist at Atrium Health in Charlotte, North Carolina.
Thank you, Dr. Fainstad. Brooke is a 55-year-old woman who presented to my internal medicine clinic to follow up a recent ER visit for a wrist fracture. She reports tripping over her porch steps and denies any other injuries other than a few bruises, and denies precipitating factors such as lightheadedness, dizziness, or palpitations, and has no significant medical history. The wrist was set at the ER and the pain has been minimal. However, her sister who accompanies her today expresses concern that the patient has been visibly tipsy when she took her to the ER and believes that her drinking has become a problem. Upon further questioning, Brooke admits to 2 or 3 glasses of wine most evenings after work and typically finishes the bottle solo on the weekends. She denies any problems with her behavior, stating that she enjoys the wine and that she isn't an alcoholic. Her sister then shares that she suspects another recent fall also involved alcohol. Brooke again denies, stating she has always been clumsy. Her social history is remarkable for living alone, working from home in a successful marketing job, and exercising, including playing tennis with friends. She has no history of other drug use and no mental health history. On physical exam, she is well appearing, has 2 healing contusions on her shins. Her wrist is appropriately casted, and her cardiac, neurologic, and abdominal exams are unremarkable. Just prior to the conclusion of her visit, her sister discloses that their father suffered from alcohol abuse and died from liver disease. She doesn't want her sister to follow in her father's footsteps and ask for help.
Okay, Dr. Fu, it sounds like this patient's struggling with her alcohol use, but I'm not sure she's ready to call it a problem or to cut back. Can you walk us through how you would approach the issue with her?
Yeah, as I mentioned, there is something of a delineation between alcohol use, problematic/risky alcohol use, and alcohol use disorder. But if we're going to focus on the patient here, a lot of this is going to be highlighting where are the problems or where are the situations where this is not aligning with the things that she wants in life. In characterizing alcohol use disorder compared to other substances, one of the difficulties is that, hey, it's legal. Lots of people use alcohol without problems. And on the flip side, lots of people that don't have an alcohol use disorder run into issues with alcohol. The nature of it is that it's an individualized basis. And the way I access these conversations and whether or not treatment recommendations come up, things of that nature, is really just based off of, according to the patient, which one of these factors and outcomes with their life don't align with what they want secondary to alcohol use. On the physician side, I'm always very respectful of how in primary care, there's a limited amount of time you have with patients. So with that, I do still try to encourage screening. And there are some tools that are much more useful in detecting issues relatively quickly. There's the Audit C, which is very good for identifying alcohol-related issues, the CAGE questionnaire that a lot of people learned about in med school, cutting back, eye opener, things of that nature. Those are quick, but if you want to be more comprehensive or do something in your waiting room, there are some other tools that capture more than just alcohol. There's the TAPS, which is the Tobacco, Alcohol, Prescription Medication, and Other Substance Use tool. That one is free to use. There's a patient-facing one and a provider one as well online that people can click through with their patients. Last time I timed it, maybe 3 to 5 minutes. Granted, if you have 15 minutes, that's a chunk of time, but I still try to encourage doing so. When we're talking about alcohol use disorders versus problematic alcohol use, the NIAAA does define high-risk drinking. So there is a stratification between men and women. For men, it's 4 standard drinks, and standard drinks would be, a glass of wine or a 12-ounce beer or a shot of liquor. So for men, it's 4 drinks in a day or 14 in a week versus women, who would be 3 in a day or 7 a week. And a lot of evidence keeps coming out that supports this idea that there's no such thing as a quote unquote safe amount of alcohol, right? So the WHO has done this. There's a few more international bodies and lots of papers that support this. And this does stand in contradiction to what some people will say, like, oh, a glass of wine is good for your health, things of that nature.
Mm-hmm.
And I always have a hard time arguing with anecdote, but if we're going to go from a statistical perspective, this is what I'll rely on. So that's the definition of high risk drinking. But I more so like to meet patients where they are. So the DSM-5 is the guide for diagnoses, and that'll tell you when somebody has an alcohol use disorder. And, that's important for billing and all that kind of stuff that physicians have to deal with. But I really like to guide it in terms of the themes that the DSM has when it talks about alcohol use disorder, right? So there's 11 criteria. The ones that most people are probably most familiar with are the pharmacological ones, where it's tolerance and withdrawal, right? The one point of clarification I want to make there is that tolerance and withdrawal to a substance specifically does not define a substance use disorder. Substance use disorders, more so from a thematic perspective, come up as continued use despite consequences. And when we're looking at the 11 criteria in DSM, if you were to break them down to themes, they break down to these themes of 1, impaired control, social impairment, and risky use, right? So impaired control would be, repeatedly trying to quit or reduce how much alcohol you're using, cravings throughout the course of the day, using more than you want. Social impairments are, hey, this is affecting my ability to work. This is affecting my family relationships. I no longer go to my knitting circle because I'm too hungover to make it over at 8 a.m. on a Saturday. These are examples, and risky use is tricky. It's not like people are going into more dangerous neighborhoods to get alcohol, but if we really expand that, if somebody is going 40 minutes out of their way to pick up 1 or 2 bottles of wine and only pick up 1 or 2 bottles of wine because they know they're going to drink more, but they're doing this 3 or 4 times a week, that's a few hours a week that they are sacrificing in service of their alcohol use. I would consider that problematic. So I really, with patients, I'll try to outline all of these different ways in which alcohol takes away from the things that they want to be doing, right? So in our case, she has some physical injuries, right? There are some risky issues. She's having ambulatory issues associated with alcohol use. She's doing it by herself, right? In a sense, I wonder what she'd be doing if it wasn't for the fact that she was drinking the bottle of alcohol by herself on the weekend. This is, straining her relationship with her sister. And not only that, it's causing some discord in the family because there's a family history, which is a point towards her genetic risk for it. But like these are factors that I would focus in on with Brooke regarding her alcohol use. It's one of those things when somebody has difficulty acknowledging whether or not there's problematic alcohol use, I'll point out these things. I'll do a wider screening. Again, this takes time, but in primary care settings where people have a higher benefit of having longitudinal relationships with people, you might know that, like, hey, this person hasn't played golf in a while, and that used to be the only thing we talked about for the first few years. What's going on there? Is there a relationship between the substance use and what's going on there? So it's really nice because the symptomatic burden of alcohol use is directly how you can get people to engage and motivate and really acknowledge the issue, what's going on.
I find that to be so true. The audit is one that not audit C for screening, but the full audit, going through it. And as you go through it with a patient, you're probing them for how they reflect on ways that it's impacting their life. And just as you said, that becomes fodder for motivational interviewing. And it highlights exactly what they want out of life that alcohol's in the way of. And it helps them get to an agreement that, yeah, this is a problem.
Yeah, it's pretty great because one of the things I like about my field of work most is that the outcomes is entirely patient function. The way they experience their emotions, their feelings, these are really important. But I like to tell people, it's like, hey, are you doing things that matter to you? How do we get you to that point, right? There's something that's really enticing about helping somebody get custody back. I mean, I'm biased. I don't like chasing people's hemoglobin A1Cs. That's me. But there's something about the work especially when you're able to work with somebody about their alcohol use disorder and substance use disorders in general, you get them to the point of where they want to be. It's a direct impact.
Yeah, it's a good way to think of it.
Yeah.
Okay, well, assuming we've gotten to the point that she's open to some interventions, can you walk us through some of your initial non-pharmacologic interventions?
Yeah, of course. I'm a strong believer that if you're going to intervene, you should have a goal in mind. So this is something that I will always determine with a patient. Now, the conventional wisdom is that, hey, the goal of problematic alcohol use is to stop alcohol altogether. And for some people, that is the goal that they want. But there's definitely a population of people where their goal is to have a reduction in alcohol use as opposed to full abstinence. One of the tricky things that I navigate with patients is how do you set a realistic goal and how do you set a goal that they might not have necessarily have full confidence in? And I'll always give the example of, outcomes from risky or problematic alcohol use in a sense of this. There are lots of people that'll go out for a happy hour, have a few extra drink, maybe get pulled over a DUI, significant consequences from alcohol use. Now, the difference between a person that undergoes that and a person with alcohol use disorder is that instead of a possibility of that being the case, there's a likelihood of that being the case. So I'll say it's like rolling a dice every time. Is there a chance that somebody with an alcohol use disorder can have a few drinks and not have it escalate? And the answer is yes. I'm not going to lie to patients and say that every single time you drink, you risk dying. I'm not going to say that because it's not the case. But the probability that there is going to be significant outcomes or consequences as compared to, when we're identifying what the problems are, the possibility of that is so much higher compared to the person that doesn't have an alcohol use disorder. So they need to decide, how frequent or how willing they are to risk those outcomes. So those are the conversations we have even before we talk about interventions. With regards to non-pharmacological interventions, there is a Cochrane review that shows that as an independent factor, participation in 12-step groups, such as Alcoholics Anonymous, there's other ones like SMART, they are an independent factor to establishing sobriety and more likeliness to accept treatment. So this is a factor that's really, really important. They also help with treatment adherence. But as a psychiatrist, one of the things I always try to remind myself and a lot of my colleagues is that talk therapy, learning coping skills, better understanding the points of distress in your life are important. So engagement in individual therapy, cognitive behavioral therapy, there's lots of forms of talk therapy that can be really, really powerful in treatment of alcohol use disorder. If we're looking at the effect of therapy by itself, the number needed to treat is somewhere between 8 and 9 for somebody to have reduction in alcohol use, right? That level of intervention, even without using medications, can be really, really powerful.
And that's for 12-step or a mix of these modalities?
Mix of modalities. Yeah. I think the review I was looking at just kind of covered all of them at once. But again, outcomes outside of just sobriety or reduction in drinking also include like adherence to treatment, things of that nature. So it's really, the way I'll put it is it can't hurt to encourage somebody to participate in that.
Okay. Well, before Brooke stops drinking alcohol, it's important to consider her potential for alcohol withdrawal, both because of the obvious concern of withdrawal complications, but also as a trigger for her to continue drinking. This challenge comes up for me maybe once every month or two, where I have a patient who's finally motivated to stop drinking and they want to do it cold turkey. And it makes me a little nervous about how that'll play out. And I never feel super confident about gauging their potential for a complicated withdrawal and if I'm counseling them on the right approach to stopping alcohol. Can you walk us through how you would approach this for Brooke?
I agree that the biggest concern is going to always be safety. As most people know, alcohol withdrawal can be a fatal syndrome. And what that comes from is the unopposed excitatory neurotransmitters activity in the setting of not having alcohol. The brain is really good at adapting to toxins, alcohol being one of them. And because alcohol is excreted in a zero order metabolism, there's actually a relatively predictable withdrawal time window. Seizures can happen anywhere between 12 and 48 hours after the last drink if there's significant tolerance and withdrawal. Delirium tremens, which could be a syndrome of hallucinations, autonomic instability, and or temperature dysregulation that happens anywhere between 48 to 96 hours. And usually once people are out of that 6 to 7 day range window and they don't have significant withdrawal syndromes, that's when I feel, they got through it and I don't need to monitor it as much. But like you mentioned, complicated withdrawal is one of those things where you're never sure when it's going to happen. The shorthand way to predict it is that if they've had complicated withdrawal in the past, they're more likely to have it again. There is a phenomenon called the kindling theory, where because of the adaptations that the brain makes to having alcohol, repeated complicated withdrawal, seizures, things of that nature will beget more likelihood of that happening again. So that's the first thing I'll ever screen for. Have you ever had a seizure in the setting of not having alcohol? Have you ever had confusion? Those are the places. There is a scale that predicts alcohol withdrawal severity. It is a 10-item scale. It's called the Prediction of Alcohol Withdrawal Severity Scale. It's not too long to go through, but that would be one of the other things that I use to measure riskiness of withdrawal management. And if anything looks like a history of complicated withdrawal or a relatively higher scale on the pause, I'll encourage people to go through an inpatient detox if that's the case. Outpatient detox really should be limited specifically for people that have a lower likelihood of complicated withdrawal. And when I think about that too, I also take into consideration medical complications with cardiac issues, neurological issues, hepatic issues as well.
There's such a narrow range, it feels for me, that I'm concerned enough about them having withdrawal symptoms to, say, give them a benzo taper self-administered at home versus just that small window before it starts becoming so concerning that they need to do inpatient detox. I feel like most people are either really no risk of withdrawal and going to do it by themselves at home, or they're risk of withdrawal and it seems concerning for complicated withdrawal and they're going to do detox. And I just so rarely find myself in that window where I want to offer some pharmacologic assistance in their withdrawal management. Do you find that those patients exist? And how do we identify just that best case scenario?
One of the things that comes to mind is this idea of available resources. I'm in Philadelphia, so I have a wealth of resources. But even then, if some person doesn't have an insurance that can cover a detox or anything of that nature, I may be more inclined to address this. So there's a healthcare system aspect to it. But in terms of specifically patients, the short answer is if they go to detox, you're in the clear. But outpatient withdrawal management, more often than not, I have a very long conversation with the patient about the risks associated with this and how I probably still would prefer them to be in a monitored setting. More often than not, the patients that I'm doing this with are the patients that recognize there's a risk for withdrawal, but given some other lifestyle situation, they'll elect to do this. And how I settle this in terms of my own anxiety is I will check in with them daily while I'm going through this, right? It's a 5-minute call tops. And like I said, once you're outside of that 5, 6, 7 day window, you're in the clear. So if it is the case, I will still, I won't let anybody detox without medications. That's for sure.
I like that, and it really does seem in many cases it's the least bad choice for the patient that wouldn't detox otherwise or can't access. And yeah, I really can't help but call them daily because I wake up thinking about it.
Yeah, exactly. So, I think one of the things we don't talk about frequently is what it feels like to be a provider treating these things. And you have to manage your own comfort regarding this. If this is something that people are uncomfortable for, I would very seldom find a situation where a provider is forced to do this, But I think if we're going to focus on patient goals, sometimes it is the lesser evil.
Let's go ahead and wrap up with some take-home points, and we'll get into our pharmacologic agents and some of the novel therapies in part 2. 3 quick take-homes I've landed with is diagnostic tools for alcohol use disorder, such as the audit or the DSM criteria. They can be useful for helping patients understand the significance of their disorder and offer a framework for motivational interviewing to get them on the right path. 12-step programs, cognitive behavioral therapy, and other non-pharmacological resources are the often first best step with a low number needed to treat, and multiple interventional modalities often complement one another. The PAWS scale, PAWS scale, helps predict a patient's likelihood of complicated withdrawal and can help determine the safest setting to quit drinking alcohol.
The opinions expressed are those of the reviewers, authors, and commentators and do not necessarily represent the views of Oakstone Publishing. Please review the complete prescribing information of specific drugs or combinations of drugs, including indications, contraindications, warnings, and adverse effects before administering pharmacologic therapy. Thanks for listening to CME Essentials in Hospital Medicine. To learn more, visit oakstone.com.